Thanks to everybody who's joined us so far. Will not be too much longer. All right, so let's get started with this evening's Info Day, Digital Info Day session. This webinar this evening is going to focus on living well with myeloma. So we've had a huge amount of questions submitted already, and we've tried to group these into topics. So don't worry if your question's not answered. We're going to try and cover as much as we possibly can. And you can always contact us after the session on our info line or on our Ask the Nurse email service. If you want to chat to each other, you can use the chat function on the bottom. If you want to submit a question, it's the question and answer button at the bottom. So both of these options are at the bottom of the screen. The webinar is going to be recorded and will be available to watch again shortly after we finish. So first of all, I'd like to introduce myself, if I may. So my name's Ellen. I'm one of the myeloma information specialists here at Myeloma UK. I've worked here for almost 18 years. I joined Myeloma UK in 2003 when it used to be called the International Myeloma Foundation UK, which was a bit of a mouthful, so we don't call it that anymore. So I used to work in the Royal Infirmary in Edinburgh as a qualified nurse, and I did further training in cancer and palliative care and joined Myeloma UK to work on their, my main role is working on the helpline, the free phone helpline, and answering queries by email. So when you phone the helpline or email Ask the Nurse, you'll get replies either from me or from Sarah or Kim. That's my two colleagues, and we all work very closely together. Sarah, Kim and I speak to many patients and families every day on the helpline. We're there to answer questions, we're there to clarify anything you're not sure of about myeloma and its related conditions like plasmacytoma, MGUS, smouldering myeloma, and AL amyloidosis. And we're also there to be a bit of a listening ear. So now I have great pleasure in introducing this evening's guests, our expert panel, and they are an expert panel, 3 of the top clinical nurse specialists in the country. So I'll start with Sarah Henshaw. Sarah is a clinical nurse specialist at Nottingham City Hospital, and she's been the myeloma clinical nurse specialist for over 11 years at the Centre for Clinical Haematology. Sarah has set up and run 4 nurse-led clinics, and she's also a member of the United Kingdom Myeloma Forum Executive Board. And we were delighted when in 2019, Sarah agreed to join our board of directors. Welcome, Sarah. So Grace Milner is the clinical nurse specialist at Guy's and St Thomas's NHS Foundation Trust, where she has worked since qualifying in 2004. And I'm delighted to say that Grace has recently won a Rising Star Award from the Royal College of Nursing for her outstanding contribution to nursing. These awards were part of the Royal College of Nursing's celebration of Black History Month. So well done, Grace. That's an amazing achievement. Absolutely delighted.
Thank you.
And last but not least, we have Tanya Burton, the clinical nurse specialist from Cardiff and Vale University Health Board. Tanya's been a qualified nurse since 2008 and joined the haematology department at University Hospital Wales in 2015. Tanya spoke at the British Society for Haematology last year, highlighting the needs of patients, and she will do the same again this year. So I wanted to talk a little bit, in case you're not aware of Myeloma UK, I wanted just to give you a brief overview of what Myeloma UK is and what we do for patients and their families. Myeloma UK is the only charity in the UK that is dedicated to myeloma and its related conditions that I mentioned previously. We provide tailored information and support for patients and their loved ones. We provide educational programs and resources for healthcare professionals, and we have patient advocacy and research programs. So we are passionate that patients get the right treatment at the right time. Unfortunately, Myeloma UK receives no government funding, so we rely almost entirely on the generosity and support of our wonderful fundraisers. We couldn't do what we do without them. So I'm going to go straight on to some questions, and the first group of questions is around diet and exercise. And I'd like to ask Tanya in the first instance if Solomon has asked a question here, Tanya, about what, if any, foods should they be avoiding?
Okay, well, thank you for the lovely introduction there. And that's a really good question. It can depend on treatments. If a patient is on particular treatments, we would ask them to avoid a few foods, which would be green tea, grapefruit, or Seville oranges for certain types of treatment. If somebody is not on treatment, we don't limit them on anything they can eat or drink at all. However, if they're going through transplants, then we would probably advise them to follow a neutropenic diet, which would be given to them in the hospital. But other than that, we would say just eat well and enjoy.
Yeah, absolutely. Healthy, well-balanced diet is always
Absolutely.
good. Yeah. Grace and Sarah, did you want to add anything to that with regard to diet?
Yeah, I just wanted to add about if you've got renal impairment, that there are specific renal diets that your renal clinicians would give you the advice on what you were supposed to be eating and not eating, because obviously sometimes when you've got renal impairment, you have to have a low potassium diet, things like that.
Absolutely. Grace, did you want to add anything around diet? And
no, I'd agree with the ladies.
Absolutely, absolutely. It is quite a bit of a hot topic, and people often ask as well about supplements like turmeric and, yeah, as Tanya mentioned, green tea. There's no stringent research evidence that these things are beneficial, but we would always suggest on the info line speaking to your team before you start taking any dietary supplement. So the next question is also diet related, and it comes from Samantha, and she is looking for advice for her mum. Her mum is going through chemotherapy at the moment, so she's on treatment for her myeloma, and her enjoyment of food has almost completely disappeared. Is there anything, Grace, I'll address this to you first if that's all right. Is there anything you can recommend for patients who are struggling to eat when they're undergoing treatment?
Yeah, I think this is quite a common thing that we see for a lot of patients. I'm sure you do get a lot of calls through a helpline about this, Ellen. Patients do struggle, especially on chemotherapy with treatment, with their diet. I think it's really helpful to eat little and often, so you have this little, not to overpile plates, not to feel overwhelmed with meal times or making a big fuss of meal times. Trying to have things that you enjoy, and snacks. And almost a bit of things that we told historically to avoid, like having donuts or Kit Kats around, things that you think, oh, mum fancies a cream cake, let's get a couple of cream cakes in, and enjoy those foods that normally we might avoid historically. And if it's something she needs to put on weight, for example, using alternatives like butter or adding cream to mashed potatoes or full fat milk might be helpful. Also, if there's a problem around nausea or vomiting, those should be addressed by her clinicians or nurse specialist, because they can have a real impact in your diet and taste changes if you've got nausea and vomiting.
Yeah.
And also seeking a dietitian's advice. Most centres should have dietitians available, and most of them are conducting telephone consults during this period. So seeking advice from them is always helpful for supplements, etc.
Thank you, Grace. That's really good. And I think we always say that even if your appetite is poor, if you can still manage to drink plenty of fluids, you're doing yourself a big favour. Tanya and Sarah, did you want to add anything to that question about someone struggling when they're on treatment to eat and to taste?
I know, I totally agree with Grace there. It's definitely little and often, and of what you fancy, and the rules kind of go out of the rule book of a healthy diet. It's what you fancy when you can.
That's right.
Yeah, I would totally agree with Tanya and Grace, and particularly with the healthy diet going out of the window when you're on treatments, and particularly when you're post-transplant phase, it's really important to get the calories in there. So I always recommend that people use full-fat milks, cream, butter into the mashed potatoes, anything to calorify the food up at that point. And that's probably just as important during the general treatments as well.
Yeah.
Because your body uses a lot of energy when you're on chemotherapy, so you need to get those calories in.
Yeah. You do have to be in the best possible physical condition to tolerate some of the tough treatments that myeloma. So a healthy, well-balanced diet, getting that nutrition in you is really, really important. And I think we would always say as well, don't suffer in silence. If you are struggling, let your team know. Yeah. So the third question we have around this is a question on exercise. So Sarah, are you able to perhaps tell the audience tonight what might be safe or unsafe exercise-wise, and perhaps what might be best if you're really struggling with fatigue, for instance?
So I think from the point of view of exercising, that's probably not safe when you're suffering with myeloma, particularly if you've got severe bone disease and problems with your spine. We always advise that you avoid doing anything that you're putting extra strain on your spine. So things like golf. I know a lot of retired people like playing golf, but the twist action of the swing with golf can be quite difficult if you've got spinal disease. High impact sports like squash, rugby, those kinds of things, we tend to tell people to avoid that kind of thing. And if you're a gym goer, we tend to tell people to avoid any high impact machinery and any heavy weights, things like that, because again of the bone disease. Safe kind of exercises and exercises that are particularly good for fatigue is potentially swimming if you're not post-transplanting, you're not neutropenic and at risk of infection. And even if you can't swim, just going to a shallow warm pool and walking up and down the pool, that's really good exercise that can help. Stretches generally, low impact sports, tai chi, yoga, walking, running if you like running, as long as it's not long distance marathon running, it's really good because that's not too big impact. Exercising on bikes, exercise bikes, machine in the home, Pilates, anything like that is really good. And I think a little bit of daily exercise helps with fatigue tremendously, and I'm sure the girls will agree with me. I always recommend that patients try and put even just a short 15-minute window a day, even if they're feeling really, really down, to do some kind of exercise, even if it's just going for a walk to the local shop for the paper.
Yeah, absolutely good advice there. Thank you, Sarah. Tanya and Grace, did you want to add anything around exercise there?
Not a lot, just totally agree with what Sarah's saying again then, and it's really key not to feed that fatigue. You know, it's so easy once you're so fatigued of just crashing on the sofa and not doing anything. So I encourage, even if you're just getting up, to make your own cup of tea and walk out to the bottom of the garden, because the rest you'll get will be so much more natural, and your body repairing itself. But yeah, totally agree with Sarah.
Yeah, I agree. And I think at the moment with the current pandemic, it's really difficult to think about getting out of the house and what can I do, what's achievable and safe for me to do right now. And maybe having little goals like Tanya's just said about getting up to the kettle. And, you know, I've got a patient who did the marathon on his balcony, you know, so having those goals or the achievable things that now sort of making things a bit more fun, or you know, climbing the stairs or taking that washing, doing those little things each day, having those goals.
Definitely, I agree. Thank you. And I think it's really important that you don't beat yourself up if you do have an off day. So if you have a day where you absolutely feel not like doing anything, have a sofa day, have a duvet day, but then maybe the next day just, and it's a good idea also to keep a bit of a diary and to build up any exercise slowly, and not go rushing into anything too vigorous too quickly. So those are all really important tips. Okay, so we're going to move on to our next group, our next topic, which is managing the complications of myeloma and any side effects that treatment might have caused. This is quite a huge topic, but we'll try and cover some of the basics here. So Tanya, I'd quite like to ask you, peripheral neuropathy is a really hot topic. We know that there are a few treatments for myeloma that can cause neuropathy, and it can be quite debilitating for some people. So what tips, what can you suggest for people to try and manage their peripheral neuropathy?
Okay, the most important thing of managing neuropathy is you have to speak to either your CNSs, your clinicians, you have to let them know. And the most important thing, the message I want to get over firstly about what we can do to help it is that if you don't tell us, we can't help you. And so many people when they're on treatment think we're going to stop the treatment because they've got a little bit of neuropathy. That is not the case. What we don't want it to do is become a permanent problem and become lifelong for them. So there are lots of things we can do. Now, some centres, and I know Sarah's got this, complementary therapy, they've got on tap, which maybe Maggie centres in local places can offer things such as acupuncture and lots of different things there. If not, you can always speak to the pain team. They can sometimes pop you through to some local acupuncture, or they can prescribe some creams that sometimes help. There are some medications that you can have out there that are kind of nerve blockers that will kind of ease the symptoms, but that's not the road we really want to go down straight off. If it's something that's drug related, we want to try and alleviate it then, because I just can't get over the importance that this can be irreversible unless we do something up front. And it's being mindful of how we describe it. A lot of people might just think it's tingling. Well, what tingling might be to me might be a burning sensation to someone else, or it might be walking in snow boots to somebody else. So the best way to think about it is what is normal for them is what is normal now before they start anything. That's normal to them. So any changes we want to know, don't home in on specific words.
Yeah, thank you. Sarah, Grace, did you want to add to the peripheral neuropathy question?
I completely echo what Tanya said. Sorry, Sarah.
Yes.
Just that it's important to let us know. If we don't know, then we can't help, and we can't stop or reverse the changes or the damage that might have already happened. So it's really important to let us know, or let your team know.
Thank you,
Yeah, I echo everything that Tanya says, and particularly that important message of making sure that your team knows and how you describe neuropathy, because like Tanya says, everybody describes it very different. Some people feel that the feet are very cold. Some people feel that their feet just don't belong to them. It's the way that they describe it. So it's making sure that they can get it across to the clinicians properly. And the other thing that I would say is, if you've not got access to complementary therapists at your hospital, we're very lucky in Nottingham, we have access to a complementary therapist, is there's ways of doing things yourself to help with complementary therapy. So if you can buy simple creams like cocoa butters, that kind of thing, and massage them into your feet yourselves, or get your partners to massage in, or your family members, and that can help.
Yeah. Anecdotally, we've heard patients say that if they have a type of peripheral neuropathy that causes a burning sensation, then a cream that cools and is colder often helps.
Yeah.
Or you can get creams with the pepper, like capsicum in it, that is also very helpful.
Yeah, there's menthol creams and chili creams that are really good.
Yeah, I think there must have been a Zoom meeting, a support group Zoom meeting fairly recently, because we had an influx of peripheral neuropathy questions just last week from people saying that they attended a virtual support group meeting, and the clinical nurse specialist was talking about TENS machines. Now, I know TENS machines certainly do have their place, but they can be quite expensive. So I would say, don't fork out a lot of money. Maybe the physiotherapy department or the complementary therapy department at your hospital has a TENS machine that you can borrow. And if it works for you, then fork out the money. But they don't work for everyone. So just before you spend a lot of money on a TENS machine. So it's a bit of a hot topic, peripheral neuropathy. And yet, as you all say, the key is report it to your team as soon as it becomes an issue. There's a lot that can be done to manage treatment-related side effects. It's not, as Tanya said, it wouldn't necessarily mean stopping the treatment. It might mean adjusting the dosage somewhat or taking it in a slightly different way of the drug that's causing it. So that's really good, thank you. So the next question we have is around bowel issues. So some treatments we know can cause gastrointestinal disturbances, constipation, diarrhea, even nausea and vomiting. And that can have a hugely negative impact on people's lives, and the quality of life can drop quite dramatically. So Grace, what would you suggest for someone who has challenging symptoms around constipation or diarrhea or bowel issues?
Yeah, like you say, it can be debilitating for some patients if they've got constipation, very severe constipation, or diarrhea. I think it's really useful to have a diary, keep a diary about when it's happening, if it's coinciding with treatment days, also how your bowels were prior to starting treatment, or it can be, in some cases, for example, amyloid disease related. So keeping a diary about how it's happening and how it's impacting you. Keeping hydrated is really important for your bowels. Some of these treatments we know, like lenalidomide, can cause severe diarrhea. We know around the days of Velcade that can disrupt the bowel habit as well. And as I said, with amyloid, we know that can interfere with the bowel. So keeping hydrated is really important. And as I said, keeping a diary. But reporting it to the team, what the symptoms are, what the stool type is, if you're having any incontinence, any accidents, just to making sure there's no infection component there, so that can be ruled out and be treated if needed, because we know that patients with myeloma are more susceptible to infections. Making sure there's no other underlying issue such as cord equina, so any cord compression that might be causing the bowels not to be functioning properly. That could be an emergency that they need to be seen. The patient needs to be seen as soon as possible. If that's all ruled out, then you can, maybe the consulting team or the clinician team will prescribe some loperamide or some cholestyramine, which we know can be effective with patients on chemotherapy treatment related diarrhea, for example. Or if there's severe constipation, then medications and laxatives to help alleviate the symptoms can be very helpful. But I think initially keeping a diary of the symptoms and when and where they're happening, and if there's any correlation to any treatment, is really important. And also to keep hydrated, keep the kidneys functioning well.
Absolutely. Good advice. Thank you, Grace. Tanya, Sarah, did you have anything you wanted to comment on about bowel-related issues? I'm sure you get asked plenty of questions from your patients and their loved ones about bowel-related issues. What would be your top tips?
I echo everything that Grace says, and I'm sure Tanya will. I totally agree with everything that she's said. I think as us as healthcare professionals, it's really important for us to understand people's bowel habits. And I know some of my patients think I'm absolutely obsessed with the bowels because I'm always asking them about it. And it's important for us to know, because then we know we can refer to the relevant healthcare professional that they need, because sometimes it might need a gastroenterologist, for example, it might need dietitian input. To change around your diet that you're actually eating, because sometimes treatment-related diarrhea, even though cholestyramine helps, you might need a low-fat diet and things like that. So yeah, echo everything that Grace has said.
Thank you.
Yeah, me too. I totally echo what both of the ladies have said there. I will say as well, you know, the bowel subjects, as Sarah said, it's our bread and butter. Nothing embarrasses nurses. You know, it's almost like we thrive on talking about people's bowels, to be honest. But we cannot help people, again, like going back to peripheral neuropathy, unless they tell us about it. And some people do find it really embarrassing to actually bring it up, but we don't find it embarrassing at all. So if we're asking you the questions, just be honest. We're not going to stop your treatment. We're going to help alleviate those symptoms and make life more manageable.
Lovely. And someone's just popped a question in there. Richard has asked, could it be confused with IBS? Of course, if you've got an underlying bowel condition, Crohn's, IBS, that could, the treatments could make that flare up, absolutely. And it could be a new diagnosis. And as Grace already said, it could even be as a result of an infection. There are certain infections that patients whose immune systems aren't so strong are quite susceptible to, like C. diff, for instance. But yes, absolutely, if you've got underlying IBS, Crohn's disease, things might just flare up. So do let your team know. Yeah, and bowels, nurses don't mind talking about bowels at all, not in the least. So we also know, moving on along to a slightly different living well with topic, patients do struggle often with sleep. And Barry is asking, what can he do to help improve his sleep? And we know that the good old dexamethasone is a big culprit here. So Sarah, I'd quite like to ask you, if you don't mind, what you would suggest to someone who's struggling to sleep.
Yeah, it's definitely the dexamethasone a lot of the time. The devil in the dex, as we call it. I haven't come across a patient yet in 14 years of being a myeloma nurse specialist that enjoys taking dexamethasone. That's the first thing to say. Sleep patterns, trying to get to sleep at night. Sometimes it's about having a healthy sleep pattern. So it's about keeping your routine going. Even if you have a bad night because you've taken your steroids that day and you've been up and down all night and you've not been able to sleep, don't be tempted to lie in the morning after for too long. You need to get yourself out of bed and keep yourself going in that routine. That can help. Also thinking about general sleep habits and sleep hygiene, so making sure your bedroom is set up in a way that's calming to be able to get yourself to relax and go to sleep. I know this is like talking to your children, but make sure gadgets are removed out of your bedroom, TVs not switched on, or lights and little lights on your TV. Make sure you've unplugged the TV from the wall so the light's not shining into your bedroom. Blackout blinds and curtains are always useful if you live in an area where you've got street lights outside to aid the relaxation before bed so that you do fall asleep properly. Some people like white noise, and I know you can get fancy white noise machines, but something as simple as having a fan switched on in your bedroom and the noise of the fan can help with relaxing you and going to sleep. I know my son uses that quite regularly to get to sleep. And also relaxation techniques before bed. So if you're good at using mindfulness, things like that, to be able to relax before you go to bed. And I know sometimes people use their phones for mindfulness apps before bed. That's probably not the best thing, but if you can just do some deep breathing exercises before you're settling down and going to sleep. Some people enjoy reading a book before going to bed, things like that. Anything like that to try and get into a sleep routine. From the physical aspects of the dexamethasone to help you at night and go to sleep, take it in the morning, take it early in the day. The amount of patients, and I'm sure Grace and Tanya will agree with me, that will come, I'm not sleeping right, and then when you investigate when they're taking the steroids, they're taking it at 8 o'clock at night before they go to bed. That's why they're waking up at 2 o'clock in the morning, bright as a button, wanting to decorate the spare bedroom. Yeah. So yeah, that's another key thing with your dexamethasone.
Yeah, lovely. Thank you, Sarah. Tanya and Grace, have you got any hints and tips to help people get a better night's sleep, especially when they're on the dreaded dex?
Yeah, I totally agree with what Sarah's saying, and we always advise patients to take their dexamethasone in the morning. However, I'm going to totally contradict that just for a few. There are some that it takes longer to absorb in. So if they are taking it in the morning and they're finding they're awake right through the night, we have got just a few that we have said take at night just to trial it, to see, so to go just before they go to bed, take it, they sleep, then when they wake up the drug is actually then at its full capacity. But that's not for everybody. Do speak to your nurse specialist and your clinicians. Another time, at some others, what we do is play around with the DEXA. Again, it's all the same theme is coming through everything. Always talk to your specialist nurses or your clinicians, because some of them we might be able to just drop the dose or drop it and taper it off over a couple of days, because that will work for one person. Because as we've probably said all the time with myeloma, it's always with everything, it's not one glove that fits all. So it's all about tailoring everything to individuals, because it is most importantly about the quality of life. There is no point everybody persevering with all these treatment regimes if their quality of life is poor.
Okay, absolutely. Grace?
Yeah, no, completely echo what both the ladies said. Yeah, and especially Tanya at the end there about quality of life. It's about getting the right balance between the treatment and the quality of life.
Absolutely. It's always mostly a balance that can be achieved. Yeah, mostly it is. We've had just a couple of questions pop up in the Q&A box there. One perhaps a bit related to the bowel issues we were talking about, and I know we love talking about bowels as nurses. So somebody has asked, can the blood thinning injections you have to prevent blood clots, can it cause blood to be found in the stool, in the motions? Is that possible? I shall ask Tanya.
That's a good question, really. I think if anybody's is seeing blood in their motions, I think firstly they really need to speak to their clinician about it. Yes, it could be that, but it could be, if you're seeing it in your motions, I think it's something we'd want to investigate a little bit further personally. I don't know about you ladies, what do you think?
Yeah.
Yes. Yeah.
I agree with that, Tanya, totally.
Some patients who are perhaps on iron tablets can have a bit of a black stool, can't they? So that can be a bit scary, but perfectly normal. So yes, any blood in your motions, if you see any blood when you go to the toilet, do let your team know, and they will want to investigate further for sure.
And I appreciate, again, we're talking bowels, it's embarrassing for some people, but again, we cannot help you unless you tell us about it.
Yeah, absolutely. So we have a question that came in earlier around managing excessive sweating, especially at night. Now, I know from my experience on the helpline that this isn't one that we answer particularly commonly, but it is an issue for a few people. So, Tanya, do you have any suggestions about why people may be sweating excessively?
You're right, it's not a question that I actually get a lot, but obviously there's a few people out there that it's causing problems for. You have to ask your question, is it male, is it female? Is the person asking questions, are they male, are they female? How, the age of the patients, are they possibly going through menopause? Are they having some drug-related issues? Now, I understand we have the odd few patients on lenalidomide that can cause a little bit of sweating. And if it's excessive in night, again, this is when kind of things get thrown out. We usually ask people to take their lenalidomide in the evening because it makes them feel sleepy. However, if one of the side effects they're experiencing is the sweating, we might say, can you take it earlier on the day and play around with it a little bit? But the usual sort of things is like good bed, like Sarah's talked about, having the room calm. It's also like good hygiene in the bed, make sure you've got nice cool sheets on, you're not, having woolly jumpers on up to here and all the rest of it. But don't keep windows open with a draft as such, because that, especially in the winter, it's going to cause cricks in your neck, back pain, it's going to colds, coughs and all the rest of it. But yeah, it was an interesting question, that one.
Yeah. Sarah, Grace, have you come across myeloma patients saying that they sweat excessively?
Yeah, I've seen that quite a bit actually, and part of my dissertation that I've just completed, I found that actually both Tanya's mentioned about menopause in women, but obviously in men, if you have low testosterone levels, that can cause sweating at night as well. And it's quite common, particularly with people that have been on treatments and have been living with myeloma in the long term, for these kind of hormone levels to be affected. So yeah, definitely important to report it to your doctors and your nurses at the hospital to make sure that we can do physical investigations to see if there is anything we can replace to make life easy.
Sure. Grace, anything to add there? No?
I completely agree. Again, it's about reporting these things, isn't it? And letting the team know how we can help. Yeah.
And it could be completely unrelated.
Yeah,
from
exactly.
what Sarah says. I mean, if your thyroid's a bit a bit low as well, you can sometimes get a bit sweaty. And if you've got maybe a low-grade underlying infection, that can make you sweat a little bit as well. So definitely worth reporting to the team as always, and they will want to know about it. We had another question come in there on the question and answer box. Grace, I might ask you this to start off with, if you don't mind, just so that we're not all talking over each other at once. This question is around eye issues. Are there any common eye issues that affect myeloma patients, or is it always unrelated?
We see it quite commonly with patients on Velcade, some rarities in Daratumumab, but mostly in Velcade patients we see the folliculitis in the eyes, the eyelids, and we've actually got a good relationship as such with that. We have a joint clinic with our ophthalmologists in our eye casualty. So it is a common thing that we do see, and normally topical treatments for the eye drops, and titrating down the Velcade doses help with that. But it's something that we do see.
And sometimes we know that long-term use of steroids can cause cataracts, can't they?
Exactly.
And things like blepharitis. And Tanya, Sarah, any eye issues that you've come across in your clinics?
Pretty much what Grace said. We see a few with the Velcade in the eyes there, but again, sometimes people start to see blurring. That's what we noticed just before the cataracts they're needed with the DEX. So again, it's don't suffer in silence. Tell your clinicians, and maybe, you know, if you don't want to tell your clinicians, go and get your eyes tested at your opticians.
Yeah, sure.
Yeah, floaters as well. That's another problem that you see quite a bit with Velcade in particular, and also dry eyes, as simple as that, and making sure that you're using eye drops and get the doctors to prescribe you eye drops if you're suffering with dry eyes, because that can be quite painful.
Yeah. And something we've come across, quite rare, but for someone who's perhaps newly diagnosed or relapsing quite aggressively, who has a very high level of the abnormal protein in their blood, it can cause a condition called hyperviscosity, where the blood's a little bit thicker and a bit stickier than it should be, and the blood vessels at the back of the eye are very delicate and they don't like any changes in their environment. So sometimes if your myeloma is newly diagnosed and you have quite a bulk of myeloma on board, you can have a bit of blurred vision caused by that. It is pretty rare, but it does happen. Okay, so we're going to move on to our final topic of the evening, which is looking after your mental health. So we've just had one come in on the question and answer box that I'll actually ask first, if that's all right. So John has asked, he's newly in remission. Do you have any advice on how to deal with relapse anxiety? A very common one, I'm sure. Tanya, would you like to take this one first about relapse anxiety?
That is a really good point, and unfortunately, in my experience, when people first relapse, sometimes the news is harder to take than when you're first diagnosed. What we don't want, you know, you're in a good place when you're in the disease has gone to sleep for now. You don't want to waste this time waiting for it to come back, because it will take over your life. You need to enjoy your life and forget about it. You're being monitored by your clinicians. They're watching your bloods. We know you've got the disease now, so it's not going to be whereas a presentation before or incidental finding. We're waiting for it, ready to pounce, ready to, you know, nip it in the bud sort of thing when it happens. And I just think is just enjoy your life and don't. It is a real tough one, I think, you know, just waiting. So many people, I think people who aren't on treatment or their disease is very stable or it's asleep for now, is sometimes harder for people to cope with than when they're on actual treatment. But the main thing is talk to people about it. Don't suffer in silence. A lot of my patients will say that they feel they don't want to burden family and friends because they're not on treatment, because they feel that people aren't interested then. Well, it's always best to talk, and if you can't talk to them, talk to your specialist nurses or your clinicians about it.
Absolutely, yeah, absolutely. Sarah, you must see quite a few anxious patients in your clinic. Any suggestions about how you would cope, how you would help them to cope?
I mean, I think as a nurse specialist, you know your particular patients that suffer more with anxiety leading up to coming for the appointments at the hospital and finding out the results, particularly like Tanya says, those that have got very stable disease and have had very stable disease for a long time. And those particular patients, I kind of pick them out and get them to contact me before their appointment so I can talk to them. I don't necessarily give them the results because I think that's what their clinic appointment is about, but I kind of give them the reassurance and talk to them about how they're feeling, and if they're feeling okay, give them the reassurance that actually if you're feeling okay, your blood results are probably going to be okay, to build them into the clinic appointment. And that way it kind of doesn't mean that when they come for the clinic appointment, it's an absolute release at that point.
Sure, sure. Grace, how would you speak to a patient who came to your clinic and said that they were really struggling with anxiety?
Yeah, I think a lot of patients do, and I think as Sarah and Tanya have said, not everybody voices it. So I think it's good that they opened up and want to talk about it. Having a good support network is always helpful. Having friends and family, having future plans, and I think for a lot of us patients at the moment, the current pandemic is meaning that this is highlighting a lot more for us. Our current situations, our surroundings, not being able to see people face to face, our normal activities, and daily living is completely hindered at the moment for patients with myeloma or on treatment. So there is added anxiety at the moment, but it's trying to maybe think about the future, looking forward, thinking, maybe making activity lists. What would I like to do at this point when the things are guidelines are lifted? What can I do with my friends and family? Maybe thinking about Zoom meetings with people. Having a good book, maybe starting up a book group or something like that with other myeloma patients, actually sort of trying to channel your stresses and anxieties into other areas, I think can be really helpful for some people, or even things that they can do in their local communities, food banks, helping other people, sort of looking at how other people in their own communities maybe could be struggling, not with myeloma, but with other issues, and how that they can support and channel that into other areas could maybe be helpful for them. And I think really, if they can, writing things down, so maybe they think they can't talk to friends and family, but actually sending an email, writing a blog, writing something for Myeloma UK, Myeloma Matters to be published, for example, how that can maybe benefit others from their own anxieties and feelings.
Sure, absolutely. No, that's really, really good. Tanya, did you want to add anything to that?
No, I totally agree with them, and that is a really good idea, Grace, writing things down and sharing with other people in the community with myeloma is where they will get a lot of support from. So, if there's a local support group that are doing Zoom meetings, or are they socially distancing meetings? I know it's very different in England at the moment to Wales. All the devolved nations, we're all very different of where we can go and what we can do. But like this sort of platform as well is very, very good for people, because it's people asking questions that what matter to them.
Absolutely. I think it's a great idea keeping a bit of a diary, isn't it? Because sometimes your anxiety can be sparked by what's happening to you in the day, and you might notice if you're keeping a diary something that triggers it. Are you particularly anxious later on in the day, first thing in the morning, when you're waiting for your test results? That's always a really anxious time. So even when your myeloma's in remission, in plateau, very stable, the anxiety around waiting for those test results can be quite overwhelming, really. And I think also another time we hear where patients do feel particularly anxious is there is always a bit of a time post stem cell transplant, isn't there? About 6 months or so after stem cell transplant, when patients been in having the transplant, they've had a lot of input from nurses, doctors, and they've had people fussing over them, and then they're sent home and they feel a little bit abandoned and they feel a bit isolated, and they start, the thoughts just multiply out of control. So we often have patients calling us around about that time after transplant just to say that their anxiety is through the roof. So yeah, keeping a diary is always a good idea. Having achievable goals, as you say, Grace, having something to look forward to, even a small thing, is really, really important.
Mm.
You did touch on, Grace, there, the particular anxiety folks are facing right at this moment with the COVID-19 virus and with the new restrictions that have come in. And I know it's different in different parts of the country, but with specific regard to looking after folks' mental health in this time in your area, I'm going to come to each one of you one at a time to ask if you'll talk a little bit about how you're helping people to cope in this current situation. Sarah, what about you?
Well, obviously, Grace and I are both in England and we've just gone into lockdown. So it's very difficult. I've had lots of patients ringing me today saying, I want to see my family. What am I supposed to do? I had a very strange phone call with a gentleman who said, work's told me I can't come into work because I'm classed I was in the shielding group before and I want to go to work. And it was like trying to talk them around that. I think it's a very lonely time for people that have had to be shielding, that have elderly, even without illnesses and living on their own. I think it is really important if you're on your own to create those bubbles with another family so that you can still get that social contact. Like Grace has already said, Zoom meetings. I mean, there's 60 plus people that have dialed in via Zoom to this evening. So people know how to use the technology with your family and your friends so that you can, instead of just having a quick telephone call, let's have face-to-face interaction, things like that. I think that's really important. I think also, particularly coming out of the last lockdown, we started saying to some patients that actually for your own mental health, if it is more important for you to go out, meet with a family member in an open area where you can social distance whilst doing it, but you can physically see them, we actually started saying, do it, because it was more important to have done the risk assessment and look after your mental health than to keep yourself locked up in a house. And I think moving forward through this lockdown, initially we'll be saying, let's make sure, keep you safe and stay in the house. But I think if we see people that are really struggling with the mental health, we will start giving similar kinds of advice.
Yeah, I totally agree, Sarah, and we pretty much say the same on the info line as well. It's a scary time, and we've got a big, long, dark winter looming ahead. Perhaps it wasn't quite so bad in the spring and the summer when you could get out, but with the colder weather coming, people are in a very precarious situation mental health wise. Tanya, I know it's a bit different in Wales, the rules are a wee bit different. So maybe you could tell us a little bit about how you're helping folks cope specifically in the COVID-19 environment and how their anxieties are being supported.
So we've changed our practice as many centres around the UK have. You know, we've gone a lot more virtual, telephone consultations, video consultations. We even managed to have a local private hospital we managed to take over for a little bit to have face-to-face consultations. That will be going, and everything will now be coming back into the hospital again. We want to reiterate to people that the hospital is open, business as usual. We are not putting any services on hold. We are not stopping any services. We are here to be contacted with all the contact numbers that we have been and always have been. I've tried to catch up and touch base with a lot more patients that tend to be maybe don't have any family contacts, or their family are over in England or Scotland or around the world, so they're a little bit more lonely. So it's just for us as clinicians and our team, the myeloma team especially, knowing as Sarah said earlier, we know our patients very, very well, so you kind of can earmark who needs that extra support, who needs that extra phone call, just knowing caller at the end of the phone does help, but it's reiterating to everybody, just because we might not actually be seeing you physically on your appointment, we are still very much at the end of the phone, if not more so now, because we are very, very aware. We've arranged a lot more delivering tablets to patients, so they haven't even got to have the worry about coming in. And as we said, I'm down in Wales now. Our lockdown is finishing on Monday, so we will be encouraging people to go out and daily exercise, not to go crazy. It's not a free for all, everything's open, but it is just be mindful. But I think the others will probably, I hope they'll agree that myeloma patients are very good at shielding anyway and looking after themselves, as are all the clinicians. So for us, I don't think it's been asking too much, just asking them to go the extra mile. But I totally agree with what Sarah did, and that's exactly what we did down here. Is when we saw people really struggling, we did say, you need to meet up with someone, you need to go out and do something, and we gave our full blessing to do that with our support.
Yeah, I think folks need to weigh up their own kind of risk. I mean, obviously, if you're a patient newly diagnosed on very potent treatment, your immune system is going to be more struggling, more immunocompromised. Or, you know, someone who's been in remission for 3, 4, 5 years, their immune system's probably quite robust, and maybe as robust as it's going to be. Still at risk though, even in remission, patients will always be immunocompromised. So you've kind of got to weigh up your own risk. Grace, I know you're in busy London. I'm sure socially distancing must be pretty tricky. How would you talk to your patients about their mental health, particularly in this COVID-19 climate?
Yeah, we've made a lot of changes, like Sarah and Tanya have just spoken about, and it has been very difficult in central London, and most patients would be coming up on the train, tube, packed buses to come and to access our services. So we've made a lot of changes in the community in the wider area of London, with hubs for patients to have mobile bloods, making it a much more safer experience for them, posting out and couriering out all their medications to them. So a lot of our work has gone virtual, almost sort of 90% of our work has now gone to virtual, and seeing those patients who are, you know, critically unwell face to face if required, and making those changes, as Sarah and Tanya have also mentioned about the rules. You know, as you said, it's about the risk versus benefit. You know, if actually I had a patient in clinic last week who is in a nursing home, he's on a 4th line of therapy, and actually she's widowed, she's got no children, and what's treatment achieving? What am I gonna, you know, I'm sort of bound in a nursing home. What am I living for? You know, having those conversations, wanting to get back to the nursing home to be around familiar faces and people that she knew, and stopping treatment, because what was the future going to hold for her currently, and having those open conversations with people, I think, is really important. I think it's really important to acknowledge, as Tanya's saying, with people who are vulnerable and alone, who've got no one locally in their support bubbles, and as Sarah said about giving them the opportunities to open up their support bubbles and saying, actually, Fred down the road, why can't, you know, let's get together with him and, you know, make those contacts with people, and trying to get them to reach out and pick up the phone to other people, maybe putting again in a diary of, I'm going to call Ellen, who I haven't spoken to since, you know, 2001, you know, trying to plan things, make contact with friends and family that you probably might not have spoken to for years, and telling them about what's been happening in your life and actually your anxiety right now, and in the pandemic and going forward, but maybe just putting yourself out there a bit more. And sometimes that can be uncomfortable for people. I know that can be sort of saying, actually, I feel alone and I'm worried and I'm scared, to say that to friends and family, but actually having those conversations can be really helpful. And unfortunately, some friends and family don't know until you tell them that's how you're feeling. They could just think, oh, there's, you know, happy Ellen again, she's doing really well, she looks great, you know, but actually inside you're suffering. So actually having those conversations and opening up that door for people to let people in, let people help you, and let people know that you're not coping, and actually you need some milk and bread and you don't know how, you're really anxious, you can't get a delivery slot from Sainsbury's and you're really anxious, or we've asked you to do a blood test and you're worried how you're going to get to on the train or get to that, having those conversations with people, and your clinicians or nurse specialists, and saying how can we help you around those situations.
Yeah. Absolutely. I think often you would be surprised at reaching out to family members, to loved ones. You might be surprised at their reaction, and people will say, anything you want me to do, if you want me to go to the shops, but take that offer seriously. It's a genuine offer, on the whole, I would say. And I think there are some kind of online resources as well. So if you go to the NHS website, there's a couple of resources there. There's Mood Zone, which has audio guides and videos where a doctor talks about low mood, sadness, depression, and there's another video where he guides you through how to control anxiety and overcoming sleep issues. So the NHS website is a really good resource. They also have an online resource called Every Mind Matters. And if you'd like to be reminded about these, do let us know and we can send you links by email, or we can tell you where to go for these online resources. So just for the end of the session, just as a bit of a wrapping up exercise, could you perhaps all give us maybe one or two take-home messages for this evening? Shall we start with you, Tanya? Your take-home message for this webinar.
Yeah, I think a big thing that's come through take home is always speak to your clinicians. You're not on your own out there. We're here. The NHS is not going anywhere. Neither is COVID as such. So to stay safe, but keep talking to us and let us know what's going on so we can help you as best we can.
Absolutely. Sarah, what would be your take-home message?
I think my take-home message almost links in with what Tanya's take-home message was, and that the thing to remember is that myeloma is fluid, COVID is fluid, it's ever-changing, treatments are ever-changing, COVID protocols are ever-changing. So keep in touch with your nurse specialist, with Myeloma UK. Myeloma UK's got a fantastic COVID hub where you can get all the up-to-date information about what you need to do as a patient living with myeloma. And I think that's really key.
Lovely. Grace, did you have a take-home message for our audience tonight?
I especially love Sarah's and Tanya's. I like Sarah's talk of fluidity.
Yeah.
Fluidity.
Yeah.
I really like that message. So thank you, Sarah. I think speaking to people, if it's your CNS, your clinician, your friend, your family, just really reaching out to people. I think this pandemic's taught us that, the Thursday clap, that people are there, that people want to interact more, and that actually the doors are closed in terms of shielding or keeping yourself safe at home at the moment, but actually open up those communication barriers through telephone, open the telephone, Zoom. These hubs are amazing that Myeloma UK have done for patients, and I know a lot of our patients have really appreciated them. So as Sarah said, using Myeloma UK and the resources on the NHS websites as well, but speaking up, use your voice.
Absolutely. Tanya, what would be your take-home message from this Living Well webinar this evening?
As I said, I think it's very much, speak to your clinicians, speak to your CNSs, stay in touch, keep talking, but stay safe.
Absolutely.
And the big thing is, at least we've got a different C word to talk about, which is Christmas.
No.
Yes, we got to talk about something else now.
Yeah, get your online shopping done now.
Absolutely. And it's like, we're not going anywhere. Sarah's not going anywhere. Grace isn't going anywhere. Ellen at Myeloma UK, we're not going anywhere. We're all still here for everybody.
Yeah, and I know you ladies have all worked in a very, very busy clinic today and a very busy hospital, so absolutely appreciate you taking the time out of your busy working day to help with this webinar this evening. And yeah, service is open as usual. Myeloma UK is open as usual. I'm working from home. I'm answering the helpline in my living room, but I have all the resources here to help answer your questions. So please do use us. So I think we've come to the end of this webinar. I hope everyone's found it informative and useful. Please have a go to our website if you'd like to watch the webinar again. We are going to continue running these digital sessions, so any announcement will be on our website and on our social media. And remember, we have our free phone helpline. The Myeloma Info line is 0800 980 3332, and you'll either get me or Sarah or Kim on the end of that line. And our email service, if you have any questions about myeloma, its treatment and care, not about your individual situation, because we don't have access to your clinical notes, but if we can answer any questions, if we can clarify anything, if we can be a bit of a listening ear. But you can email us as well, askthenurse@myeloma.org.uk. And finally, I would like to say a huge thank you to our panelists, and thank you all for watching. Please take care of yourself and look after each other. Stay safe.
Thank you.
Thank you.
Thank you.